morning. I'm Steve Baldwin. I'm the moderator for today's podcast presentation and discussion. Incidentally, I am also the editor of the Southern Medical Journal, which is publishing the article that this podcast is based on. Today, we are joined by Dr. Martin Olsen from East Tennessee State University. Dr. Olsen is an obstetrician gynecology specialist. His practice includes interest and focus on substance abuse involving pregnant women. He's been practicing in Eastern Tennessee for the past several years. Some of the audience may recognize Johnson City as one of the major communities located in Eastern Tennessee. Unfortunately, this community is also one of the most affected by substance abuse disorders in the country, and certainly in Appalachia as well. Dr. Olsen has tremendous experience with substance abuse, particularly opioid abuse in the United States. He also has been an important researcher in this domain, and he has been involved in considerable advocacy efforts related to women's health in his community in the state of Tennessee. We are blessed and honored to have an outstanding expert on this topic, such as Dr. Olsen today, and he's going to help us discuss some of the issues related to the impacts of opioid abuse among pregnant women, fetuses, newborns, and ultimately developing children. So welcome, Dr. Olsen.
Well, thank you, Dr. Baldwin, and I appreciate this opportunity to educate colleagues and other listeners to the podcast. And I'd like to thank the Southern Medical Journal for the courage it took to publish a controversial article.
Dr. Olsen, let's begin by reviewing some of the history and current status of the opioid abuse epidemic in the U.S. in general, and Appalachia, especially Eastern Tennessee, in specific terms.
Yes, certainly. If we doctors step back and think about how we got an opioid epidemic, we'll remember that in the 1990s, there was a growing movement of pain is the fifth vital sign and no patient should have pain. You know, the younger doctors may recognize those little smiley faces and frowny faces we see in the hospital. Those date from that era, where Purdue Pharmacy and others convinced the doctors that patients shouldn't have pain, we need to write for more opioids. I can remember as a young doctor being told by a hospital administrator, your patients are complaining of pain, you need to write for more pain medicine. So let's keep in mind, we doctors did it. We had help. We had help from the Joint Commission that said pain was the fifth vital sign. We had help from specialty societies that said write for more pain medicine, but we did it. So we have to think about that. And Appalachia is rural America, and the opioid epidemic is worse in rural America at the present time it is in urban America. In 2021, over 100,000 Americans died from opioid overdose, and opioid overdose now leads automobile accidents as the cause of death. So it's bad nationwide. It's worse in our rural areas. So let's shift gears a little bit to medication-assisted therapy. And in an effort to fight the opioid epidemic, we now have large numbers of patients receiving medication-assisted therapy. In Johnson City, Tennessee, we actually have 14 medication-assisted therapy clinics in this community of 60,000 people, and that compares to 4 OB/GYN practices. So this paper we're going to discuss explores the possibility of an unintended consequence that as we give more medication-assisted therapy, there's a parallel rise in neonatal abstinence syndrome. And let me just define that term, neonatal abstinence syndrome. That is the withdrawal that newborn infants experience from substances. Some authors prefer the term neonatal opioid withdrawal syndrome, or NALS, but state governments use NAS, and we're talking about state government statistics, so we have to use the same terms that the state government has. So from here on out, we're going to talk about NAS.
Thank you for that introduction here. You recently authored a paper on this topic. Can you review the issues and the findings of your paper to orient us maybe a little bit more granularly?
Certainly. So the paper is entitled Rise in Neonatal Abstinence Syndrome Rate is Associated with Rise in Buprenorphine Prescription Numbers. And this is the first report which documents an association between rising NAS rates in a region and increased buprenorphine prescribing. So we were able to find data for the years 2010 through 2018. During that time in Southern Appalachia, the rate of NAS rose by 335% in just an 8-year period. The number of buprenorphine prescriptions rose by 413%. So you can see those curves are very similar. So we do suggest a reevaluation of buprenorphine prescribing recommendations during pregnancy. Now, let's be clear, this article shows an association. Association is not the same as a cause and effect. Further research would be very valuable. And I would also like to point out that the article showed that overdose deaths continued to rise during that same time interval. So for Appalachia, at least, a massive infusion of buprenorphine did not result in lowered deaths from overdose. Now, some folks may say, well, maybe it would have been worse, and maybe they're right. There's no evidence to say it would have been worse without buprenorphine. All we can say is that the massive infusion did not lower overdose death rates, and at the same time, NAS rates did rise.
I think also part of the background on your paper may be some of the advocacy efforts in Tennessee here. Can you talk a little bit about that and how that contributed to your motivation for this paper?
Well, the opioid epidemic is not at all static. One of the things for us to consider is how it's changed over the years. So it started as pain pill epidemic, and patients trust doctors. Doctors give them medication, it must be safe. And then the patients become addicted. And in Tennessee and many other states, we've really ratcheted down the number of opioid prescriptions. So those numbers have dropped, as the article shows. So even though opioid prescription numbers have dropped, NAS continues to rise. And that leaves a gap. And for those patients that don't decide to fill that gap with medication-assisted therapy, they may decide to use illicit medications. So the first thing that they used was heroin. There was a major heroin increase, but lately it's fentanyl. And I think it'd be useful for your listeners to hear about how dangerous fentanyl is. So I'll refer to Sam Quinone's books. One's called Greenland, one's called The Least of Us, for those that are really interested in learning more about this. But fentanyl is very, very potent. The ingredients are made in China. They're shipped to Mexico. Factories in Mexico make the ingredients into fentanyl. They ship it across the border, and in the United States, it's then turned into counterfeit pills. So a patient did bring some counterfeit Oxycontin into my office, and I couldn't tell the difference between that. Her drug screen was positive for fentanyl, so I knew there was fentanyl on it, but you couldn't look at the pill and know. The manufacturers in the United States, well, there's no quality control with illegal drug manufacturers. So they use a blender, the same blender that you or I might go to the store and buy to make a smoothie with. They're making fentanyl pills. And one pill may have the right amount to get a patient high, and the next pill has 50 times as much, so that patient dies. Because blender's just not, it's not going to be an equal dose in every pill. So that's why fentanyl is so dangerous and so scary. So this evolving epidemic means we have to evolve to the epidemic. As far as my own interest in this topic, it really comes about from the fact that patients are so motivated. And yes, these are patients with many, many challenges. The opioid addiction the patients face is often a symptom of all the other problems in their lives. But you take a person who has not done much for herself in the last sometimes decades, who suddenly becomes pregnant, and she says, well, I'm going to reassess. I'm going to turn my life around. And I find these patients very, very inspiring. So those that are willing to work, they work hard. And those that aren't, then, there are 14 other clinics in Johnson City, Tennessee, and we make sure they get the care that they need.
Mm-hmm. Well, thank you. I live in Alabama, and unfortunately, Alabama doesn't collect very many statistics on pregnant women and substance abuse. So we're um, experiencing the same issues in general, but unfortunately, we don't have any data to really monitor quite where we're going or the ups and downs of all of this. So, kind of interesting issue. I think the federal government is starting to insist more and more for data from states. So, perhaps some of that will get rectified via that.
It's certainly my hope that this article will provoke government agencies to look at that link further, because to be honest, this is an article that should have been written by a government agency. They should have pulled their data. The story of the article is that I was looking through Tennessee data one day on the internet, and I saw the curve of buprenorphine prescriptions over the years, and I said, now wait a minute, I've seen that curve before. And so I pulled the NAS rate curve, and they were parallel. And so I got with a medical student, Summer Shore, who had an interest in opioid addiction. And I said, well, Summer, she actually had a summer research project. So this is a medical student summer research project. So she approached me and said, what project can I do? And I said, let's look at a whole region. And she was very, very diligent, did a great job, worked with our ETSU statistician, Dr. Lewis, to produce this paper. So it is my hope that government agencies will say, wait a minute, let's look at our own data and delve into this further.
I think probably some of our listeners may not be as aware as you and myself regarding the impact on the fetus and on newborns of opioid abuse. So perhaps you could begin with the pregnant woman, and I'll maybe talk a little bit more about the pediatric end state of it, since I spent most of my career as a pediatrician.
Yeah, and that's a great point, Dr. Baldwin, because folks are frequently aware of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, and they think that's the whole story, but that's really only part of the story. So the first part of the story is, well, what causes NAS now? And in Tennessee, the answer is buprenorphine. So 2/3 of NAS is prescribed buprenorphine. And then there's another function of illicit buprenorphine, because buprenorphine in my region is a street drug. And so in Johnson City, it's well over 90% of the NAS is related to buprenorphine. So step one is no, it's not fentanyl and heroin and pain pills that are causing NAS, it's buprenorphine, which at some level means that might actually make it easier for us to do something about it. And as far as how commonly do patients have babies with NAS? A large national study said 52% of patients on buprenorphine will have a baby with NAS. So let's talk about those long-term consequences, though. And we're getting into some areas of controversy. So I'll tell you about the literature. You know, the official, I would say that the American College of OB/GYN has evolved from there are no long-term effects to we're not sure that there are long-term effects. But I think the data would say that there definitely are long-term effects. So, for example, the baby's heads are smaller if they're opioid exposed. And, you know, this is not rocket science. Get on a tape measure, their heads are smaller. Their MRI evaluations are altered. Their brain volumes are less. And there's an increased death rate. Now, interestingly, the increased death rate in one study was not in the babies with NAS. It was in that 40% that didn't have NAS. And the theory is that, well, here's a baby with NAS. Baby has the need for resources. Let's make sure that baby gets what the baby needs. Oh, good, this baby didn't have NAS, so great, go on and have a good life. Where actually that baby needs resources too. So that's the theory as to why the death rate's higher in that group. The babies are born with lower birth weights. They're more likely to have feeding difficulties per the neonatologist at my own institution. And they have decreased educational achievement. And this information goes back to the 80s when there was an outstanding study by Phil et al. Out of Vanderbilt on Tennessee children that shows decreased educational achievement. But there are multiple papers that are decades old that are showing decreased educational achievement. So in my community, 10% of patients are on buprenorphine when they conceive. So every first grade teacher's got, on average, 2 or 3 kids in her class that were opioid exposed newborns at the time of their delivery. And for myself and for others in my community, our belief is we just can't keep doing what we've been doing for the last several decades. It's 10% of the population. So guidelines, in my view, are there for folks to look at and say, well, yeah, that guideline applies to my patient and I'm going to follow it. On the other hand, if the guidelines don't apply to your patient for whatever reason, you're allowed to say, well, let me look at the evidence myself and make my own decisions. And in the case of my community, 10% of babies with a condition is just, in my view, too high for us to say, let's keep doing what we've been doing for the last several decades.
Well stated. My experience kind of begins in the neonatal stage, and those that end up having withdrawal syndromes can have a rocky course, but most of them get through that part of it. The other issue is that this ends up including other substances besides opioids and whatever. Probably one of the biggest problems is still fetal alcohol syndrome, which caused a big epidemic of damaged children. And it was the leading cause of developmental disorders in children many years ago. It's still plentiful, as you can probably imagine. The other issue is that once these babies are discharged from the nursery, they're not going back into a conducive environment for good development and good health. Physical violence associated with drug abuse by the parents or significant others, or however it shakes out, is a really big issue. And so trying to coordinate socioeconomic and clinical issues to get these children through the first year of their lives and get them started on support services to enhance their development going forward, it requires an awful lot of coordination among a bunch of different agencies and specialists, and is a difficult issue. These children generally qualify for Medicaid, early childhood developmental assistance. The families automatically generally qualify for Medicare, Medicaid, food stamps, and other tangible resources. And also they need some watching to make sure that the child's not in an unsafe environment if they're on the upswing of their drug abuse problem, or there's violence or crime or other issues that are associated with the opioid abuse, and putting the child at an unsafe situation as well. So once you get through the nursery and are able to go home, the story isn't over at that point. You really got a big issue and a lot of work to do to get them into school and hopefully have a future that's not too bad.
Well, I agree completely. And one of the keys, I think, to confronting it is to start as early as one can. So I think in our traditional system, it's Dr. 1's the obstetrician, Dr. 2's the medication-assisted therapy doctor, and then they'll pass off the newborn to Dr. 3, the pediatrician, after delivery. And in our system here, so we started our program 2016. It was based on patient request. Patients asked us to please help them lower their medication dose. And we said, well, there's this thing called autonomy. And if the patient wants it, that's what we should do. And by the way, they're doing it on their own anyways, and they seem to be doing fine. And so it really started as, oh, let's try this because the patients want it. And now it's developed into a program that has, doctors and nurses and case managers and psychological help. And so from our view, we're starting this process as soon as we meet the patient. So we've got our case manager to figure, is it a safe home environment? Well, if the partner's on meth, it's not a safe home environment. So unfortunately, the patient has to decide, am I going to let my baby not come home with me, or am I going to tell him to leave? And so she has the chance to make that decision when she's 18 weeks gestation, not when the baby's born in her arms and she has to figure out where am I going to live. We have a very close working relationship with the pediatric department, and they have a special clinic just for NAS graduates, and in they go, and they're watched in this clinic that's called the Baby Steps Clinic. So one of the things I think we need to think about is, well, first, a previous paper y'all were good enough to publish showed that our NAS rate is 0 when the patient's buprenorphine dose is 0. That was November 2020. And NAS in Tennessee is over $40,000 person. So my opinion is that we can have better outcomes that don't cost the system any money. Because if we take that money from treating NAS and we transform it to preventing NAS, the system has the same dollars in it, but we're going to get better outcomes because we're going to be intervening earlier. We have to change our system in some fashion because every patient I see, if I cut my, if I cut that rate for those patients that I saw, then I cost my hospital system $20,000 a patient because I cut it by half. So for this government to go to hospitals and say, hey, help us out here, let's lower the NAS rate, and by the way, we're cutting your income, that's really not going to work. They're going to have to change the system so that the constituents that are doing the work on the ground also participate in the savings.
I think you're spot on that this is an issue that depends on the frame of reference that you look at it, and a more holistic frame of reference that is covering more of the facets of the whole issue is probably the way to go. Do you see any potential improvements to reduce the number of fetuses, at least in the short to medium term, that are becoming exposed when their mothers become pregnant?
I do, and we're getting into a controversial area. So the official statement is that dose does not affect the rate of NAS. And my opinion is that these studies do not properly track the dose. So buprenorphine is a very potent drug, formerly described as 30 times as potent as morphine. And the CDC recently removed that description because folks don't usually die of buprenorphine overdose, so they took it off. But that doesn't mean the drug suddenly became less potent. But 30 times would mean that the recommended dose by the manufacturer is 16 milligrams. So 480 morphine equivalents, or as I tell my patients that came to me on 60 milligrams, you're on 48 lortabtins a day. And some patients that are on fentanyl, they may need that much. But I've certainly seen patients that were on 6 or 10 lortabtins a day that then went to their MAT and lortabs 1-to-1, hydrocodone, to use the proper terminology. That's 1-to-1, so they're on 60 to 100 morphine equivalents per day. They're placed on 480. And that would be an explanation that might explain why the NAS rate went up when buprenorphine prescriptions went up. So these studies that said that some of the studies are very weak, that they don't even tell us the doses, but some of the studies drop the dose to all the way down to 45 or 450 morphine equivalents or 45 lortabtins a day. So they drop from 72 lortabtins a day or 720 to 45. And they said, well, look, we didn't change the NAS rate. So I would point out that there's a 2 milligram pill. So somebody at the FDA must have thought that 2 milligrams was effective. And that is the target dose for our program. So in our program, the NAS rate, the abstract presented at the ACOG meeting several months ago, we were under 10%. So the expected rate, of course, is 52%. Ours was under 10. So I think that, like many other drugs, the usual course in pregnancy and picking drugs is lowest effective dose. Well, my opinion is we need to do that for buprenorphine as well, figure out the lowest effective dose. And if we do that, then we have the chance to lower the NAS rate as long as it's safe to do so for the mother. And now we're back to autonomy here. And one of the things that I want to make sure that the listeners hear is no patient should be forced to taper. No patient should be forced to come off of her medication. In my view, the patients come into my office and we talk to them about, do you want to taper? Here's the risks, here's the benefits. 55% of the patients say, no, I'm happy where I'm at. I do not want to taper. And 45% say, I'd like to work with your program and have the lowest possible rate of drug withdrawal for my newborn. So that's their autonomy. Nobody, again, should be forced to taper. But we also need to do a better job of educating our patients about what kind of a disease their child may face. And I've seen patients on high dose in my office in tears, crying about their baby suffering in the NICU with its diarrhea on its morphine drip, with its painful cries. And they're saying, but they told me the baby would be fine. And it's a difficult conversation because you've got a patient who's got opioid use disorder. You don't want to inflict guilt on her, but at the same time to withhold the information that it could be a months-long process. The official statement calls it an expected and easily treatable disease. I feel that's inappropriate when you've got a disease that has a death rate to call it that. When it's a disease that costs tens of thousands of dollars, when it's a disease that causes the discomfort to be severe for the newborn. But that is the official recommendation. But that's the term that's used in the current guidelines. And I think the patient deserves the right to have a discussion of this is what NAS is, and this is what the long-term effects could be. And again, not all babies are going to have those long-term effects, but some are. And after that discussion, if the patient says, I think the risk of relapse for me is too high, I don't want to taper, well, then that's her right to make that decision. But if the patient says, I'd like to taper, then it's up to us to do that in a environment that's safe for the patient with proper psychological support and proper monitoring. I would like to talk just a moment about the safety of tapering. The official belief is that tapering might increase the risk of relapse. And I want to make sure we ask the proper question. So the question is not, do patients who taper have relapses, because we're talking about opioid addiction. Patients with opioid addiction relapse. It's a part of the disease process. We must accept that. We must do our best to prevent morbidity. We must give our patients Narcan. But if the patient has opioid addiction, there's a risk of relapse. The question, though, is not, does the patient have a risk of relapse? The question is, does the patient who is tapering have a higher risk of relapse than a patient who is not tapering? And there's no published study that actually has two groups like that. The evidence is out there that says the risk is higher, basically expert opinion with a few articles that refer back and forth to each other. So we have unpublished data. Only at the time of delivery do we have a comparison group, but we compared our 45% tapering with our 55% not tapering, and the relapse rate at the time of delivery was the same in our unpublished study. So I would say so far there's no good scientific data that says that we are risking patients when we offer them the right as human beings to decide that they'd like to taper.
I think that was very well stated. I think one of the other issues that I've thought about on this is there a way to deal with these women as far as imparting the issues of drug abuse, alcohol abuse, smoking, et cetera, before they get pregnant? And so should we try to pass that information on during routine visits or anecdotal visits or whatever to make them aware of what may be coming if they end up abusing those types of substances and they get pregnant?
Well, I think we should, but I don't think that's happening. And the basic guidelines that are stated by the American Society of Addiction Medicine, in my view, and perhaps one of them will write in and tell us that I'm wrong, but it seems to be back to it's expected and easily treatable disease. And patients walk out of their visits believing there'll be no problem. So I think we need to do a better job educating our patients. I mean, when we get back to the cause of NAS being 2/3 of the time it's prescribed buprenorphine, we know who's at risk. It's sitting there on a governmental. These are the reproductive age females receiving buprenorphine in Tennessee. Somebody could punch print on their computer this morning, find those folks, and devise a plan to begin educating them.
Mhm.
So yeah, we can do better. I mean, that's sort of the theme of this entire discussion is we can do better. So thank you for asking that question. I was
Sure, sure. Let's talk a little bit about advocacy efforts in this, because I'm not sure that some of the information is flowing to the government or other regulators or vested parties in all of this as well.
Well, I'm going to be honest with you, Dr. Baldwin, that sometimes I feel like I am a bit alone because I'm advocating for a massive change. And medicine doesn't move quickly sometimes. It takes time to decide to make dramatic change. So it's an Appalachian disease. So for the rest of Tennessee, there are folks in other areas of the state that are now figuring out that yes, opioid addiction is a problem, and we need to start offering medication-assisted therapy to patients. Whereas in our area of the state, we have more Suboxone and Subutex than our patients probably need. And so it's just a completely different environment. So I salute the efforts of the Tennessee Health Department and others to reduce the stigma of this disease. In my view, this is a medical condition. It's got an ICD-10 code. Patient's got a disease. She walks in the door, you treat her disease. And it would be my hope that we get away from massive numbers of medication-assisted therapy clinics in the community, and it gets back to primary care doctors saying, well, look, I just made a diagnosis. The diagnosis is opioid use disorder. I'm going to write for medication to treat it. I mean, for me, that is the ultimate goal. There are huge regulatory burdens to get through that just because the patients require extra time, and doctors are afraid to take that on because of the extra time involved.
Yeah.
So there are other changes that we need to be made, but I think if we get to that system, then we're not going to have nearly the problem that we have now of too much buprenorphine in the street, because the primary care doctors know their patients. So if you wouldn't mind, I'll just talk a bit about my statement of too much buprenorphine. So again, a controversial statement, but my opinion is when doctors write for the proper amount of pain medicine, they're treating pain and suffering, and they write for too much, they have an opioid epidemic. And when doctors write for the right amount of buprenorphine, they're treating addiction. And if they write for too much, this paper raises the question, are they now being a part of an NAS epidemic? So in my community, buprenorphine is a street drug. The street name for Suboxone is Box. The street name for Subutex is Tech or Subs.
Buprenorphine is the most common prescription drug seized by the Tennessee Bureau of Investigation.
It is the only non-cannabis drug some patients have ever abused. Just yesterday I was in clinic with a medical student talking about this, and I walked into a patient's room and I said to the patients, so the medical student here's been taught that you can't abuse Suboxone. Well, they both laughed, and which is of course valuable information for that medical student. And patients smoke it, snort it, inject it, and stick it in their rectum. And so the literature out there, there's literature talking about how buprenorphine is abused for its effects. There's a belief by some writers that the only time a person would take buprenorphine illicit is as a self-treatment for their opioid addiction. And there are even some municipalities that have decriminalized selling buprenorphine. So I think this paper, in my view, raises a question that's just completely inappropriate. My view is this is a controlled substance. treated like the other controlled substances. I mean, I think all of us agree that that opioid use disorder is a disease. Let's treat like the other diseases. Well, that includes, in my view, the drug used to treat opioid use disorder. Treat like the other drugs. For me, in my community, patients tell me that they'll receive a prescription for 2 pills. They'll sell one. They'll take one, and Subutex goes for $40 a pill, so they have enough money to pay their doctor's bill to go back to the office next week. So my view of diverting buprenorphine so the patient can share with their friends would be the same as me diverting my hydrocodone that I needed for my knee surgery a couple of months ago and giving that to my friends. They're both controlled substances. Diversion is inappropriate.
Yeah, I think that's been my experience as well. I was a pediatric emergency medicine physician for many years here in Alabama. And, there were all kinds of signals, some of them subtle, some of them overt, that all this was going on. I think you're spot on. I think one of the other issues that we've identified is there a need to think more in terms of multi-specialty care for some of these patients rather than one provider provides the entire spectrum of care for these kind of situations?
Well, I think we have to recognize that in the rural area, patients have transportation issues.
Mm-hmm.
So you are correct that it sounds good to get all these minds together working on the patient. The reality of the patient is that getting her to one appointment is sometimes all we can handle. So yesterday we had, Monday morning is one of my medication-assisted therapy clinics for pregnant postpartum patients, and we had at least 3 patients that couldn't make it in that day. Or my car didn't start, my ride didn't show up, etc. So my view is that one-stop shopping is a more likely path to success than multidisciplinary input. And I would really want to encourage my sister and brother obstetricians to take this on. We believe that we take care of a hypertensive pregnant patient better than anybody else. We believe that we take care of a pregnant diabetic better than most other folks in most cases. Well, I think we can do a better job with overuse disorder than taking care of that disease process in pregnancy in isolation. And I would really encourage my colleagues to take on that challenge. It can be very rewarding. There's nothing like seeing a patient at 36 weeks gestation skipping out the door because she is so proud of what she's done for herself and her family.
I think you're correct. And if you do need bigger depth of specialty expertise, you can usually figure out a way to have that communication, and may not necessarily need to have them continuously present in the process. Are there any other further thoughts that you would like to share with the audience?
It's a process that so I'll encourage audience members to get engaged in the treatment of these patients. And the federal government now allows any doctor that can write for opioids to write for buprenorphine. I would encourage the folks to have the support of their institutions because it's really hard to do this all by oneself. I would really like to thank East Tennessee State University. The chair is amazingly supportive. The dean is very, very supportive, and they've sent resources our way. The healthcare system, Ballot Health sends us resources also. So thanks to all of them. But mostly I'd like to thank my patients. And I tell folks that listen that I have learned more from my patients about opioid addiction than from any journal articles or textbooks. So thanks to my patients, and it's really rewarding and inspiring to be there pointing in the right direction while the patient does the work of changing her life.
I would agree with you. I think some of the most satisfying patient encounters that I've had in my career have involved people with substance abuse or alcohol abuse or other types of abuse problems, and when they can get back on their feet and back on top of their game, that's really satisfying. I think that concludes our podcast here. thanks to the audience for their interest and efforts to learn more about this topic, and hopefully the expertise of Dr. Olsen and some of the new insights that are starting to develop in this will lead us to a better state in the near-term future, or at least medium-term future here. Thank you, Dr. Olsen. Much appreciated.
Thank you, Dr. Baldwin. I enjoyed our conversation.